Right. I think we should get going, Hannah. So good afternoon, everyone. Thank you for joining the webinar. First of all, I would like to thank Health Innovation Yorkshire and Humber colleagues, particularly Jess, to organize this, and a lot of other colleagues actually who have contributed to optimizing kidney health for all. Of course, today is World Kidney Day. We celebrate second Thursday of each March, and it's quite a nice time to just update colleagues on the call about what's actually happening with the kidney world. Just to say a couple of things. Yes, happy World Kidney. This session is being recorded, so hopefully all of you are okay with that. I am Sunil. I'm one of the consultant nephrologists, and I'm also looking after kidney health for West Yorkshire ICS. Along with me, I have Hannah. Do you want to introduce briefly? And
Thanks, Sunil. Yeah, I'm Hannah Beba, consultant pharmacist for diabetes for West Yorkshire ICS. Thank you.
Brilliant. So we are talking about kidneys. They are amazing. Some of you might know kidneys sort of make you wee, by which you get rid of toxins that are produced through metabolism, through whatever we eat or drink. But very few people are aware that there are many more roles of kidneys, and hence, when you have kidney disease, it can cause a lot of other issues. So just to name a few, it helps maintain the balance, salt balance, the blood pressure. It looks after the bone because the sunlight, vitamin D, you need a good working kidney to be activated into a form that then helps bone and muscles. And also, it helps the red blood cells production. There is a hormone that kidney produces called erythropoietin, which also goes with erythrocytosis, so erythropoiesis, which is formation of red blood cells. So when the kidneys are not working, you can immediately imagine that there would be a lot more issues apart from the toxin effect. So what we're going to try and cover over the next hour or so is a range of things, just to give you a bit of a taster about why we're focusing on kidney health. And what we'll try and do is do this in sort of 6 key messages. But before we go into the detail, I just wanted to say what is a chronic kidney disease and what is not a chronic kidney disease. So chronic kidney disease, by definition, you need to prove it is chronic. So you need markers of kidney damage that are 3 months apart, and they are consistently showing injury to the kidney. So that's when you define that as a chronic kidney disease. So that's the first thing, really. So got a feedback that the slides are hazy. Is that a problem for everybody? Sangeeta just said the slides are hazy. If nobody else has that issue, I'll continue, if that's okay. Oh, thank you, Alice. Let's just think that maybe your bandwidth might be an issue, if you wouldn't mind having a look. So the other thing to say, what is not CKD, is if you got somebody with an EGFR over 60 with no other marker of kidney damage, then you don't call that a CKD. That's the first key thing to mention, really. Right, so what I'm going to try and do in the talk is to go through 6 key areas today. I'm going to show you that why the Kidney Research UK and kidney community have declared poor kidney health as public health emergency. I'm also going to show you that poor kidney health does not affect everybody similarly. There are health inequalities when it comes to kidney health issues, just like with any other long-term health issues. What is also important to know is kidney health or kidney disease can cause a lot of damage quite silently, and hence it's called a silent killer. And then touch on the key challenges we have as a system. The kidney health awareness is poor, and I'll show that it's not just general public, but also the healthcare professionals. That is despite having good optimal management available. We need to up our game, and then I'll share some of the great work we are doing in West Yorkshire to improve that. So the first one is why we're declaring chronic kidney disease as public health emergency. Well, I hope you can see the slides, but 1 in 10 people have chronic kidney disease in UK, and that's rising. it is actually not only at a personal level, but also as a system level, a huge challenge. Right now, the kidney care, including dialysis, cost about £7 billion, and within the next 10 years, that will go to £14 billion. It is also predicted if we don't change the course, then the requirement or need of dialysis will be 400% more in the next 10 years. What's also quite worryingly is CKD is slowly jumping up the ladder of most common cause of premature death. Right now, it's number 10. And by 2040, it's going to be fifth most common cause of death. Now, this table comes from NHS right care scenario, which a number of people in the call would be thinking about the impact on resources and impact on finance when it comes to kidney health management. Essentially, this number is for management of one patient. If they go through optimal management through the journey of CKD into transplantation, it costs £53,000 to the taxpayer. However, if the patient's care is not being optimal, either delay in diagnosis, delay in management of complications, starting dialysis in an unplanned way, etc., then that cost is almost 6 times more. So you could see getting optimal care on few can release a lot more capacity and a lot of resources that we desperately need in NHS. So the other thing to mention here is there is a very strong link between kidneys and heart. Two major organs. Heart is the pump and kidney is the filter. When I look after kidney patients, there is very little actually I could offer in the past to protect kidneys. Main focus have always been on reducing cardiovascular disease. So why is that? So if you have stage 4 or stage 5 kidney disease, you got almost 1 in 2 chance of getting cardiovascular disease. Whereas in terms of needing dialysis, that is 1 in almost 20 times more risk that you will get a cardiovascular disease and die rather than actually have a kidney failure requiring dialysis. Almost 50% of my patients with stage 4 and 5 have got some spectrum of cardiovascular disease. And also cardiovascular CKD also increases the burden of acute kidney injury. In itself is a huge burden to the healthcare as well as to our patients. So why are we in this state where patients are living longer, but are actually living more with multiple long-term health conditions? One of the health conditions accelerating others, in this case, kidneys or diabetes for that matter, can cause both, kidney disease as well as heart disease. So those are our top sort of causes. And as you can see, all of them are on rise, whether it's diabetes, whether it's high blood pressure, whether it's obesity. Smoking perhaps is getting better, but also, people are living longer. And if you are over 60 years of age, then there is a much higher risk of chronic kidney disease. So let's just talk a little bit about the patient's journey into the healthcare system. And this slide really defines where an action can be taken to sort of prevent some of these major health issues. So, for example, I am based in tertiary prevention. So I work at downstream, very downstream, in a transplanting center, where my focus is about tertiary prevention. What that means is, if somebody is presenting with advanced kidney disease, I want to optimize their health by either having good quality dialysis or kidney transplantation, preferably, and managing other complications of kidney disease. So that's where I would be focusing what is called tertiary prevention. And then colleague like Hannah and others on the call who are from ICS will be focusing on secondary prevention. This is the core work really, where we already know somebody's got CKD or diabetes or hypertension, where we try and prevent the outcomes. And then you can keep going leftwards, which is primary prevention. So for example, patients with diabetes are massive risk of kidney disease. So when it comes to preventing kidney disease and diabetes, that becomes more primary prevention. And then you can take all the way the left shift, which is right up the upstream, which is public health. As we already said, things like diabetes, hypertension, obesity, smoking, there's a huge public health element in it to work with. So CKD poses a particular challenge to the system. If you have CKD, it is very likely that you will have 4 other long-term health conditions. Now that bar chart on the left side is from Health Foundation. It looks at all the other long-term condition. Just to give an example, if you pick up hypertension, it is likely that you will have two other long-term health condition. If you pick, whichever disease, but if the highest one is chronic kidney disease, where you have a lot of other chronic health issues. The second thing I want to emphasize here is we often sort of talk disease in isolation in terms of management targets or how we manage patients. The slide on the right side, what it shows is for the same blood pressure, which is a risk of chronic kidney disease, if we then also have other conditions like diabetes or obesity, the kidney disease progression accelerates for the same blood pressure. So this is where we need to always reflect, yes, the cough target are great, or whatever the system is giving us target are great for the overall system. But when it comes to individual patients, you need to tailor that. You may have to be very aggressive for a young person, for example, with multiple disease as compared to old patient with frailty and whatnot. So this is these are the common long-term conditions that we see in patients with CKD, hypertension being the most common one, followed by diabetes, and then chronic pain issues and depression are the next one. The number in the bracket just tells you if you flip other way around. So if you got diabetes, how many of you would have CKD? So that's 40%. If you are a cancer survivor, 17% of you would have a CKD. If you have a heart failure, 50% of you will have CKD. So you could see how kidney disease itself can make things worse. For example, management of heart failure can be very tricky if you have CKD in terms of diuretics and other drugs management. And same thing for diabetes. You have to sort of rationalize or change medicines or treatment once you develop CKD. So it is causing a lot of troubles to everybody in the system. So when it comes to CKD, 9 out of 10 patients will have other long-term conditions. That's a bold statement because that's where we need to work with everybody together. So that's why we call that as a public health emergency. If we don't do something, it will be a huge price for the society and the system to pay. The second message I want to get across is when it comes to poor kidney health, it does not affect individuals, same. There is a lot of data that suggests disparity or health inequality when it comes to CKD. The first one is this particular slide compares sex and age. If you are over 65, CKD is very common. 1 in 4 women will have CKD compared to 1 in 5 men. If you are over 75, 3 out of 5 women will have CKD. So both, there is more in female than male. But when you come to my dialysis unit, it's completely the other way around. There are more men on dialysis than women. So perhaps something there that women can last longer with CKD, but when you get into dialysis, it's more men. Now, this will surprise many of you. So this is a data on ethnicity and age. And what you're seeing here, the bottom line is the white Caucasian, where the CKD is increasing with the age. And you can see how different it looks like for ethnic minorities, particularly Asians and Black. It almost looks like a Mount Everest compared to a hill when you compare to white Caucasians. So and there are a number of reasons that we can go into a bit later on, time permitting. So this year, World Kidney Day, the focus is about equity of access to care in primary care, equity of access to secondary care. Now, this particular data is the most recent data from Kidney Renal Registry from UK that shows when patients are starting dialysis, how well in advance they knew the kidney team. So these are all the centres in Yorkshire. You can see about 20% of people in Bradford are not known to renal centre a year before they start dialysis as compared to Hull, where 40% of them are not known to renal services. So there is something happening in that patient's journey where we could work to get them early. And getting them early means that people who are suitable can have transplant and not necessarily slip into the dialysis world, because it does take time to prepare for dialysis. So how does that look like in terms of social deprivation? This is some of the work I did in health equity as a health equity fellow in West Yorkshire. And what that showed was 50% of late presenters comes from an IMD of 1. So these are 10% most deprived community. If you look at overall CKD, 50% of CKD is in core 20 practices. So that's 20% most deprived um, uh, individuals. And if you look at 10% most deprived, because Leeds is, for example, Leeds is a city where the 10% deprived population is same as a town of Halifax. So if you look at 10% more deprived, 1 in 3 CKD actually are in those 10% most deprived areas. So there is a gender or sex gradient, age gradient, ethnicity, as well as socioeconomic gradient. And I just want to show a couple of more slides on this equity issues. This is some of the work that we are doing at the tertiary prevention. So this is just giving you a flavor that ethnicity, the CKD starts 15 years early compared to white Caucasians. It's about 5 times more chance of needing dialysis or requirement of dialysis. If you look at the transplant waiting list, 1 in 3 people waiting for a kidney are from ethnic minority. Yet, if you look at general population, that's about 14%. If you then look at the waiting time, the Asians and Black ethnicity have to wait longer, about 6 to 12 months longer compared to the white colleagues. And that's because the organs that we get after death, 95% comes from white Caucasians, and very little actually comes from Asians or Black ethnicity after the death. And the same thing actually is there when it comes to living donor kidney transplant. So um, overall, 1 in 3 kidney transplant comes from living people. If you look at white Caucasians, that's 35%, whereas if you look at ethnic minority, that is 17%. So there is a lot of work we need to do, as you can see, along the path of getting that equity, getting that care. The other major one, which is very close to the heart, is equity of access to research studies. And this is a data from Leeds where we are looking at how well we are doing in terms of recruitment to a study, and a matrix called participant prevalence ratio. What that means is you look at the number of people who are in the research study, and then you look at number of people who have that disease. Ideally, it should be 1. If it is equity of access, that number on the y-axis should be 1. You could see that that is slightly above 1 for white Caucasians, which is the blue line there, which has been very steady. The Black ethnicity in Leeds, we are doing better, but then actually the number of population is very little. So, but nevertheless, we're doing good. But if you look at South Asians, which is a major population in Leeds, we've been consistently doing poor, whether that is gender nephrology trials or dialysis trial. Maybe we are slightly better, in nephrology and transplant studies, but when it comes to dialysis studies, we are hardly recruiting anybody from South Asians. So what those slides shows is kidney disease affects, unequally, but also the journey of the patient is also met with a lot of disparity. So at this point, I would say number 3 message, which is poor kidney health is a silent killer. Now, why is it called a silent killer? Majority of patients with CKDs will not experience any symptoms, and that's a common challenge that I have when I'm in the CKD clinic. A lot of my patients will say, well, doctor, I'm feeling absolutely fine. What is this all, fuss about? Monitoring the intensity every 3 months, a lot of these drugs. And I have to tell them, well, it's good you're not feeling unwell. Once you start feeling unwell, you don't need me. You need a transplant surgeon or dialysis. You need to lose 90% of your kidneys to start feeling some symptoms. And the common symptoms, if at all the patient develop, would be puffiness of the face, as you can see in the picture, tiredness, swollen ankles, lack of concentration, itchiness. So if you're experiencing those symptoms, it suggests that you need to have a check. It could be CKD, it could be other health issues, but generally those symptoms would need a check. So what we then depend is mostly on the tests, because patients don't have any symptoms. Patients are not aware, they can't tell us any symptoms, and we have to depend on urine test and a blood test. The most important one of all the tests that you can see in the picture here is the urine, because that gives a lot more information about the kidney health, and also a lot earlier than any of the tests that you got here. But equally, it's important that both the blood sugar, the obesity, and the blood pressure, they are also silent killers. They have to be measured. So those are the things that I would be doing when patients comes in the clinic, with real focus on urine, and we'll come to that in later in the talk as why urine is particularly important. So today I've got 43 champions in the call, and this is what I really want your help with. So the next phase of the talk is all about how we work together, what are the challenges, and what we are doing in West Yorkshire particularly. Well, number one, anybody who's going out of this talk today, please try and improve the awareness of kidney health to wider public. As I said, the awareness is lacking in general. So I'll show you some slides. So if you look at this survey, which was done a year or so ago, randomly selected 2,000 adults in UK, 80% of them did not know where the kidneys are. I hope you all know where your kidneys are. 80% did not know what they did. They didn't knew that they are a vital organ. They filter the blood, and quite shockingly, 25% thought that you can live without them. They are of no use. So that's just tells us, the scale of what we are dealing with. But what is really worrying for me and Hannah particularly is people who are at risk. So these are people with diabetes, hypertension. 60% of them believed that they were not at risk of kidney problem. Those are our top two killers, and yet 60% of them didn't feel that they were at risk. And then there were a range of things that I'm not going to go into, but generally what I'm trying to say is awareness in public and people at risk is very little. How about awareness of healthcare professionals? Well, so this is a survey done by Kidney Care UK asking 1,000 GPs about their confidence and what they do about CKD, whether they talk to the patients, whether they feel confident. And it was quite shocking, to be honest, but also tells us the work that we need to do. 6% of them felt extremely confident to talk about CKD, only 6%. And 12% thought they were not confident at all to talk about the CKD. And and only 14% said that they will regularly, always advise patients about the risk of kidney health. So essentially, the awareness is lacking across the spectrum of this, equally in healthcare and patients at risk. So let's just talk about how well we do in UK compared to America. This is American data, and they do a great job in tracking patients' awareness, particularly patients who have CKD stage 3 to 5. And you can see they are doing some good job. From 15% 20 years ago, they now got 25% of people who have CKD stage 3 to 5 know that they are at risk of kidney health. If you look at that data based on stage of kidney, stage 5 being the worst kidney disease, most likely they are on dialysis or transplant, and 99% of them knows about the kidneys. Why not 100%? And that's come down. So something to think about. I have people on dialysis. They will ask me, so when is my kidney going to get better? How many more sessions I need? So you could see dialysis means kidney is packed up totally. It's not going to recover. Yet, even at that stage, patients aren't aware of their kidney health. So that's what we are up against. So how does that affect really? Well, it affects because when you are aware of a long-term health condition, you will code them in patient's health record. Now, this is most recent data, less than 6 months old from CVD Prevent audit. What they found was in UK, 300,000 people with CKD do not have that diagnosis in their health record. Now, that is, I don't know, is that the size of Halifax? But that's a huge number of patients who have got CKD, but not in the record. Patients don't know this. The system doesn't know this, because if they don't know they have CKD, they will not have monitoring in place. Even people who are known to the system with CKD, you could see the monitoring is a bit patchy. Only 85% of them actually had a CKD blood test done in last sort of 12 months. And if you look at the urine, I keep talking about urine, and you'll know in a minute why it's so important. Only 40% of them had a recorded urine test within last year. Now, awareness is poor. The entry into the record is poor. Even if it's there, they don't get the adequate monitoring that you would want. And the price for that, you can see in this slide here on the right-hand side, is increased hospital admissions, increasing mortality. And I'll show this a little bit better from the next slide, which I'm sure you'll be bombarded with this heat map of CKD. I'll spend 20 seconds or so on this heat map. So on the left hand side, you got this lovely colorful, traffic light signal from green to amber to red. What does that actually say? So here, any patients, whether you're in a GP practice or whether you're a cardiologist or diabetologist, you can subcategorize or subclassify your patient to 15 risk category by having urine tests divided into three categories. So normal urine, no albumin, to a little bit albuminuria, to a very high albuminuria. So that's a 3 grade. And then you can divide the patient to 5 grades based on the stage of CKD. And what it shows is when you're moving from green to red, all the 10 things that I've listed on the right hand side increases. And I'm not going to go in detail of that, but if you don't do urine and if you just focus on the left column, which has got 2 greens and 1 yellow, 1 amber and red, let's assume that you don't have a urine. So the one which is yellow, where EGFR is between 45 to 60, could be in the red zone if they had the urine. So essentially, you're missing them out. You're missing the vital drugs, and you're putting them at risk of all the 10 things that are mentioned on the right-hand side. So this is a great test, isn't it? If you got simple GFR and urine, you can categorize your patient to 15 categories, and you can reduce 10 different risks. Now, you will not find any better test to do that to your patient, yet it's not been used that well. So then I'm going into my next message. I'm sorry, I'm taking this journey very quickly with the hope that we can chat a bit. So what's the fifth thing? Well, there are great management available. When I was a trainee, there was very little I could offer to a patient with CKD. But in last 5 years, this is transformed. There are lots of drugs, a lot of different classes of drug that have become available to optimize the management. And I'll just share some local data, but also international data about, despite having good evidence, nice approved, how the implementation remains a major challenge. And then, Hannah will come in to talk a little bit about what we are doing in Yorkshire to overcome that implementation challenge. So this is some slides from Yakurit. We will get that questions in a bit. Please keep coming with the questions. So Kidney Research UK saying that if you do these 4 things, guess what? You can save 10,000 lives in next 10 years. So what are those 4 things we need to do? Early diagnosis? Well, that's no different than cancer. If you pick cancer early, you can have better survival. So it's the same thing with kidney disease. By the way, I mentioned the word cancer. How many of you realize that if you're on dialysis, the outcome is far worse than any cancer, apart from 2 cancers in UK? So we are very sensitized with cancers and how bad the outcome is, yet we don't know how bad on dialysis the outcome is worse than almost all of the cancer. If you're 40 years of age and you're on dialysis, your chance of celebrating 50th birthday is 50% if you're on dialysis. That's not the same for cancer. So early diagnosis is really important. Improved management, and then starting this novel group of drug. Well, it's novel for kidney world, but it's not that novel for the world that you might come from. And the fourth thing is about increasing transplantation. So the best renal replacement therapy, so if you have dialysis and different types of dialysis or transplant, the best transplant is living donor kidney transplant. There are good data to say that if there is a living person donates a kidney, then that kidney will last longer and the receiver also would live longer. So that's what we need to try as a system is to, and you can see there is no mention of word dialysis there, because dialysis is not only costly treatment, but actually has got much worse outcomes. So what we really need to try and do is to do those early diagnosis, start treatment, and then move to transplantation. Yeah, Kieran, keep coming the questions. I'll come to that in a minute. So how well are we doing? So this is great work done by CVD Prevent in our ICS. Hopefully some of you are on the call and you can see the numbers are looking better when you compare to the national average. So the CVD Prevent is a massive database that tracks the CKD, not in complete entirety, but it does give us some valuable information. So the first thing is in West Yorkshire, we got 75,000 people with CKD stage 3 to 5, and only 1,000 or 2,000 are actually under renal services and seeing somebody like me. Majority of this is being looked after by the great primary care. If you look at the 2 things that we said, urine test, about half of the people at risk, CKD, gets a urine test in West Yorkshire. That is better than nationally. And I think this is something I know CVD Prevent and other colleagues are working really hard to improve that. The one that's been of the focus is getting treatment like ramipril and renin-angiotensin inhibitors. And you can see if you've got high blood pressure, CKD and proteinuria, 73% of them are already on those drugs. So that's really good because an optimal treatment would be around 75%, but we are not too far from that. And that's a great work done by the CVD Prevent team in Yorkshire. So comparing that with the US counterpart, we always like to do that, despite they don't have the same access of care. So the US, if you got diabetes or stage 3-5 disease, about less than 60% of them will be on ACE inhibitor. If you got diabetes, you're on more compared if you're not on diabetes. So what are these drug group called SGLT2? I'm not going to go into or explain the mechanism or all the trials, but I'm just going to talk some of the bigger data. So this is a meta-analysis presenting to you 90,000 participants in 13 different clinical trials. And if you pool all those data together, because individual, the biggest trial was 6,000 participants. So, to actually apply something being tested on 6,000 people to hundreds of thousands of people, you will be feeling uncomfortable. Well, we don't have real life data. So the first thing is, if you put all those clinical trials together, it does consistently same message. If you give this drug, it reduces the risk of kidney disease progression. It reduces the cardiovascular death, heart failure, as well as acute kidney injury. And the effect is same whether you have diabetes or whether you don't have diabetes. So that's the key message, really, because when these drugs were first discovered, it were discovered as a treatment for diabetes. The good news is it doesn't reduce the blood sugar, and hence you could actually give this to patients without diabetes as well. So what are the implementation challenges then? So this is a study from Australia where they looked at the three big clinical studies in CKD, which is Credence trial, DAPA CKD study, and AMPA kidney. And they worked out how many people would be eligible if we apply the criteria of those clinical trials. And you can see from green to blue to the purple, the number of people who are eligible increased dramatically. But currently in Australia, 4.2% who are eligible are actually getting that. Yet about 44% patients with CKD would be eligible for SGLT2. Now, the reason this set of data is important is we are thinking at the system level as how we do, roll out some of these initiatives to the bigger mass. Now, of course, rolling out means a lot of resource and a lot of, investment. And where do we get that money? But what we need to remember is the investment that we do, just like with any other investment, it's always about thinking about future, which is about a couple of years down the line. So the Australian says, if you implement this to 75% of eligible people, at a country level, you will reduce heart attack, stroke by over 3,000, and you will reduce dialysis by 1,300. Now, that's a huge number, actually. That is almost two size of Leeds dialysis population, so that can be saved to get that if we can get those drugs prescribed even at 75% of population, not even 100%. So how well are we doing in UK? So this study predates the AMPA CKD study prior to NICE TA 942. Essentially, this is a GP database looking at thousands of people. You can see almost 500,000 people. So if you look at 500,000 people with CKD, about 26% are eligible. Now that is going to change because AMPA has expanded, empagliflozin has expanded that definition of eligible people. So in the UK, if you look at the GP registry, about a quarter of them will be eligible, but about 16% of them are prescribed SGLT2. Now, you would have thought that diabetes world and diabetes kidney and the benefit it's got, that would be much better. But eligible are 62%, and only 22% of the patients with diabetes kidney disease are prescribed on that. So huge implementation challenge here. It's not that people don't want to give this drug. It's all about how we do this in a scale level. If you ask anytime, I ask my GP colleague, they will always start these drugs, but it's all about how we do this proactively. And same thing in US. So patients with diabetes, actually, they are doing slightly worse than us. It's about 15% of them with the CKD that are on SGLT2 inhibitors, whereas we are about 22%. So let's look at real life benefit. We didn't go into individual studies. We talked about the big data and the Australian one. And real life benefit, this is a UK data from primary care. If you give these drugs for 2 years to 12,000 patients, that's double than any clinical trial really, you can reduce all the outcomes. Most excitingly, 50% reduction in severe renal disease. So let's come to West Yorkshire now, because there's a lot of work been going on, and this is something you've been waiting for. So in West Yorkshire, this first couple of slides shows the prescription of SGLT2 and how well we are doing over the years. So you can see that red line. We've always been top of the pack, really. We were the second best, in 2019. We are now fourth best. The number of prescription is slowly, steadily increasing. So that is where it puts us, number fourth in the country in an ICB level in terms of number of prescriptions that we do. And if you look at the heat map, the Northeast is the highest one, followed by Greater Manchester, then few in London, and then it's West Yorkshire. But that's not saying equity of access. We might be giving a lot of prescription, but if you look at per 1,000 patients prescribed, so that's what it says. So per 1,000 eligible patients, we were right somewhere, I think 10th or something like that. Some of the ICBs have done better. They've gone over. That particular ICB is not in Northeast. It's actually in Lincolnshire, where they are prescribing a lot more per 100,000 patients. So just to show you where we are. So we were like number 4 in terms of prescription, but we are right in the middle when it comes to the country at a population level. The next thing you'll be thinking, right, well, Leeds Place must be much better than Kirklees or Bradford. But this is the data on all the 5 places in West Yorkshire, which is Leeds, Kirklees, Calderdale, Bradford, and Kirklees. So the best one, guess what, is Calderdale, followed by Leeds, Bradford, Wakefield, and Kirklees. Kirklees have got slightly lower compared to the others. So as a place level, we're all equally good. I think it will be good to have more competition to get this more. So at this point, I'm going to introduce you the 6th message, which is about, we talk about silos. And we could talk about breaking the silos, but I would say bridging the silos, because the silos are there for a good reason. You saw the CVD Prevent data. It's fantastic data over the year improvement. So we're all working in silos, doing great job, but how can we work together more collaboratively? And at this point, if I could invite Hannah to take over, and I'll move the slides. Hannah's been doing great job, to be honest. Well, before I started in this role, she was doing CareMe Group and driving the kidney health in Leeds Place, and now she's driving that across the West Yorkshire. Hannah, I'll move to the next slide.
Thanks so much, Sunil. And just to echo, I suppose, what you've said there, that is something that's everybody's business. I think kidney disease, and I think it's in some ways, the more that I think about it, it's almost the one thing that really unites us across the board. Really, that we can get so much out of each one of what we're trying to achieve by having that focus around good renal health. So I mean, it's a pleasure to say that we've finally finished our West Yorkshire CKD guideline. It's been a job of work, but some amazing input. Obviously, from my perspective, this is always a pleasure to do. We always learn things together through pulling these guidelines from across such a broad populations, and what people are seeing, what people need with regards to their clinical practice. And I think we've got such a good representation around the table at the Cardiorenal Metabolic expert reference group, but also across West Yorkshire, that's really gone into this document and really given us some reflections on what people are struggling with, what's new practice that we need to support with. So things like the arrival and the use of finerinones coming into our practice now. We're still not doing that well with SGLT2s, as Sunil's touched on. I think that we're looking at a 20% uptake at best, and obviously we need a lot more people on these medications to make a difference, and there's work to be done there from a research point of view as well about what are the barriers that people are experiencing with starting some of these medicines. Is it the people living with kidney disease, or is it people who, or is it professional barriers? So all of that is ripe for further exploration, really, and we'll look forward to taking that forward together as a city, as a West Yorkshire collaborative, and across the Yorkshire and Humber region as well. Thanks, Sunil. Next page, please. So this is kind of a brief overview of what this guideline looks like. Anybody can access it across the country. Anybody can access it. It's on the West Yorkshire, hosted on the West Yorkshire website. And as you can see here, we've already highlighted right at the top there the importance of not just kidney disease. So if you think about the CKD, kind of helps you remember that we're also thinking about our cardiovascular health, our kidneys, but also diabetes, because we know that a lot of people that go on to dialysis are people living with diabetes as well. This guideline really touches on the things that Sunil's been talking about. You know, what are those markers of kidney damage? How do we get that diagnosis done? How do we assess somebody's risk from their kidney markers? And this, it gives a QR code there to do kidney failure risk equation. Which Sunil can see here. So obviously you pop in all the readings that you get, both your UACR and your EGFR, age and sex, and it gives you what stage of kidney disease it is in a very nice readable format. Gives us that idea of both a 2-year risk and a 5-year risk there, and that gives us then an indication on whether that person needs to be referred for starters, and probably most importantly, if somebody's at that stage. And we are finding that, you know, some people, they don't have that, they haven't had that input necessarily, and we do pick people up quite late in renal disease, which is a problem. Obviously with that, we've got the EGFR. We can do that QR code and then use that equation, and hopefully on clinical systems this KFRE will start reporting out into our clinical systems, which would be really useful. So when you get your EGFR back from the labs and you've already had a UACR, it will pre-populate this, hopefully. I don't know when that's coming, Sunil, do you know?
Yeah, hopefully in West Yorkshire this will be in August. In South Yorkshire it's already rolled out and doing good. So it's all the LIM and IT update that needs to happen, Hannah. But hopefully August is the date for West Yorkshire.
Perfect. So that's really soon. So so that'll be brilliant, and that'll just keep us grounded in what that risk is. And Sunil's already shown you obviously the KDIGO heat map here, and we've added into that just a bit of advice around what you're going to do at each stage, you know, what you might be seeking. So you can see in each category there about we're going to check whether it is CKD, but also in that sort of yellow to amber, we're starting to monitor, possibly seek some advice and guidance and refer. And then obviously for most people in that red zone, we're going to be monitoring, referring, or seeking some advice and guidance at that point. And we've put in some patient information, advice leaflets and things that you can share to get that awareness, to help people. Some of these resources are available in a variety of different languages as well, so that helps us to try and reach our populations. But I think there's still quite a bit of work to be done on that front, to be honest. As we know, we've got many spoken languages across West Yorkshire, and we tend to kind of have resources in 1 or 2 or 3 maybe different languages, but not necessarily across the spectrum. Which can be a real barrier, because it tends to be our ethnically diverse populations that have a higher prevalence of kidney disease, and so really to not design resources with them in mind is not a great thing, and we recognise that, and we hope to do something about that as we move forward. Obviously here around as well when to refer. Pillars, sorry, next slide, please, Sunil. So pillars of approach to address our drivers of CKD. I think, again, Sunil's touched on some of this from a hemodynamic point of view. We're thinking about introducing the ACE and the ARBs. This is really our foundation of that medical management of chronic kidney disease. And hopefully, if we're monitoring appropriately those high-risk cohorts that Sunil pointed out for diabetes, and those people living with hypertension, hopefully we can start these really, really early on. And then obviously then we're starting to add in our SGLT2s as well, which is also has some hemodynamic, but also has that metabolic benefits as well. We've got some really exciting trial news that came out only a few weeks ago around the GLP-1s and their renal benefits. We've known this for a while from some sort of post hoc analyses of trials that have already been done around GLP-1s, but there's been a dedicated renal trial looking at semaglutide in people who are overtly albuminuric, called the FLOW trial, and this has been really great outcomes around renal health and renal protection. So GLP-1's another protective agent that we can add in to help with kidney health. And then also inflammation and fibrosis. Obviously this is where the finerenone comes in. It is a non-steroidal mineralocorticoid, so if we're thinking spironolactone, but without all the gynecomastia side effects, etc., all those steroidal things. So because it's non-steroidal, we don't get any of that. But we do still have some challenges around managing the potassium and monitoring that appropriately, which is why at the moment we've got that under slightly tighter surveillance with the renal teams, and we'll hope to bring this more fulminantly out to primary care when we've got a bit more experience with it as a collaborative effort. Thanks, Sunil. And this again just shows kind of how we can approach this this drug management over a reasonably short period of time, because what we really don't want to do is have any sort of clinical inertia. And we've built this this part of our guidance from the London guidelines, which were some guidelines that Andrew Fenkel put together, which was a 3 in 3. This was before finerenone hit, so we've changed it and we've gone 4 in 4 to save lives for adults with chronic kidney disease. And it really does save lives, and that's why we've put that in there. And we've got also around that person living with diabetes and the people who aren't living with diabetes, because we know that the SGLT2s are licensed for people who are not living with diabetes, as well as those who are. And as Sunil's pointed out, very poor uptake in the non-diabetes population. So people aren't thinking about that yet, I don't think. So that's important. And again, around optimizing blood pressure, adding in your ACE inhibitors and your other RAS blockade if you can't use ACE inhibitors, and then also considering that referral for finerenone, and doing that in a timely way, underpinned by all that lifestyle advice and cardiovascular risk management that we would want to be doing with anybody who had chronic kidney disease. Thanks, Sunil. So what have we been doing about kind of doing some project work around this? So in Leeds at the moment, we're starting a Care for Me project, and this will focus on renal health, but really it's a multi-morbidity project. So this is about us focusing on a multi-morbid population and starting SGLT2 therapy as indicated. We've really targeted our approach around primary care networks with lower IMD and with lots of diversity as well, so that we can get a real good sense of how we can approach this and get people started on it in a timely fashion. So diabetes population is really where we're trying to focus, and in order to kind of acknowledge that some of those patients are quite complex, we've put in some multidisciplinary team time with both myself and Claire Rands, with some of the clinicians that they can run through any queries or questions that they've got around that to build competence and confidence. And just like any of these projects that we've run in the past, we do find that this really helps both us learn actually as to what the barriers are, because what we think is going to work and how it works is not necessarily how it plays out in practice. So I think we will both learn about how this project can run smoothly, and then hopefully we'll be able to roll it further across the city. We're using something called the CDRC searches, which are developed up in North East North Cumbria by Gareth Forbes and his team. Really comprehensive searches around finding these populations that would be eligible in renal disease to start an SGLT2I. Costs are high, so just to give a sense of that, so obviously when we were putting in our project initiation document for this, the financial part of it was really quite the challenge, and at the same time the Kidney Research Association came out with a very detailed cost efficacy analysis. It's about a 200-page document, isn't it, Sunil? So it's a good bedtime read. But it is something that's quite enlightening about where the costs are driven within the system and where the costs release over that time. And it's a real investment for a long-term future as renal. And this is part of the challenge, is that when we don't get any sort of booster money into the system to try to float this, it's a challenge for ICBs to float this finances. But we're in for the challenge, so that's good. So costs are around £500,000 for the 1250 patients that we're planning on starting, just to give a sense of that. And we're really going to try and embed this guideline and also the 4-tier model of care that we know has been so successful in both our heart failure projects across the city, and also our 3 treatment target project in diabetes as well, to build that competence and confidence and really think about bringing specialists out into community and raising people into specialism in a primary care environment. Thanks, Sunil.
That's brilliant, Hannah. I'll just talk through a couple more slides, mainly some of the initiatives we've taken. So there's a massive project that's been, again, similar cost of £500,000 called Minuteful Kidney West Yorkshire project. So all the practices in the West Yorkshire are invited to join this. This project is looking at early identification of CKD by home monitoring on patients with hypertension who've not had a urine test in more than a year. And the reason we chose hypertensive cohort as compared to diabetes is when you look at the late presenters, it's not so much with the patient with diabetes. They do get their blood and urine done some point in their journey, but not so much with hypertension. And hence, a lot of people were presenting, the top cause was hypertension. So if your practice is in West Yorkshire and you're not part of this, please get in touch with us. That's my email. But you got a whole package here with leadership support, as well as we are looking for experts of interest for place leads. If you're one of them, please do come. And just to complete off with, we are doing a lot of work, and we really mean this as a core business. And we got passionate, people. You got Danny probably on the call, who's the project manager for Yorkshire Humber Kidney Network. We got in a long-term condition board team on board. Those were the amount of events that we have done this year. We've also undertaken a big survey in the West Yorkshire ICS. About 66 people responded, and it just tells us that we need to do more work to actually get the information there. A lot of people are not aware of KFRE, and 20% are not confident in diagnosis of CKD. So those are the things that we'll be focusing. Some other things in the horizon. We got PhD student, equity fellow. Ali might be on the call, who will be starting us with a lens of equity. We are very keen to work with industries. Of course, in this call here, you got health innovation colleague. So at this point, I'm just going to put the 6 core messages that we have taken through, and we'll open for some Q&A. So I'm just going to look at the questions. Yeah, so thank you, Karit, for joining from community point of view. And I know you've been doing a lot of great work in South Asian communities, so well done. So Subrat saying the same. So why are urine tests not done? Well, so it isn't so much of the cost really, as I explained. Some is the awareness about, some of that is where it fits in from the healthcare point of view, but also from the patient point of view. When we asked questions as, what do you feel about urine? They don't feel, well, A, they don't know why it's been asked. They don't feel that that's a convenient thing. So even if you give a pot of urine, go and have the urine done, they'll say, oh, well, I'll do it at home. And then they never get around doing it. So those are some reasons. I'm not totally blaming the patient, but it is a issue that we just need to do more. And hopefully the home urine project that we're doing, that might allow a bit more in their own convenience and in their own privacy to do that. Corinne from City Health is asking if somebody had a radical nephrectomy, how likely they're going to develop CKD? Well, so it all depends on their health and if they have other risk factors. So, for example, some people are just born with one kidney. Some people donate their kidney while they're alive. If they don't have any other health issues, then we recommend yearly monitoring for kidney health. So this is a urine test, a blood pressure, and an EGFR. Now, of course, if you had nephrectomy, you'll be having surveillance. You will be having, other tests. So if you have other healthcare issues, then that monitoring will go a bit more. So, Hannah, do you want to tackle this from Kurt is saying lack of investment into community organization? What's your thoughts, particularly on Core 25 connector programs? And there are quite a lot of work going on, of course, in the community. Do you want to take that question as why there is lack of investment?
Yeah, I mean, I think obviously we're trying to. The ICB is still in its infancy, really, and we've just got through our operating model restructures. So I think probably this is something that will grow as we get through into the next financial year. So it's certainly something that's high up on our agenda, and we have got representation around our groups that are looking into this much more detailed way. And obviously we are really married to deliver this core 20+5, so we need to scope this in a lot more detail. And until we've got agreement that we're going to move ahead with some of this renal work, which it sounds like we are, then obviously we will we will hopefully then have the resource to really drive this forward as an agenda and do all this mapping and all this connecting work and look at where our resource needs to be. Thank you for that question. That's really helpful.
Yeah, and only to add, renal network, that is a PPIE group, correct? And any other patients or public, if you are out there and you want to join the group, which is really focusing on getting, as you mentioned, correct, co-protection. We want to know your ideas, your thoughts, because often you see the whole system and the navigation in a very different perspective. So we absolutely value that. So please drop me a message or reach out. Anybody who's out there who would like to join the renal network. As I said, Danny is on call, project manager, as well as Gillian is the network manager, should be on the call as well. So yeah, drop your line in the feedback. I'm conscious we got 2 more minutes. There are no more questions on that, are there? Yes. So it says happy. Oh, Hannah, happy to share your insight. Okay. Yeah, I will connect. I know Kirit well, Hannah, so I can connect that connections. So any other final thoughts, Hannah? There aren't any more questions. You're doing a lot of work. How do you see this, kidney health within your workspace, and what else you want to do? I know you're already full plate. Anything more?
No, I just think that it's one of those things that I think, as you've highlighted, I think it's our early warning sign for a lot of things that are on the horizon, and so we don't want to miss it. So I think even if we can just embed some really basic things, it might be making sure that people have been signed up to organ transplant donor. It might be just raising awareness around that. We need to think of things that, yes, some of the drugs are really expensive, but there are things that we can do that don't cost anything as well. So I think there's something there around what basic things can we get done, what are our low-lying fruit, how do we engage? I think the question there about engaging with people and doing that patient participation bit around some of the research that we're going to take on, so important. And I really look forward to seeing what this comes to into the next few years. The ambition is there, most definitely, and I'm excited. I am.
That's great. Lovely. And honestly, we got a lot of colleagues, on the call as well, who are equally passionate and working together. As I said, this slide, I quite like this slide. We're all talking and we are working together. So I think we'll put this session in a close. Please fill in the feedback. The recording will be available on a YouTube channel, which will be shared as well. So thank you so much for your time. We really appreciate that you've given an hour to come and listen and to contribute this. So thank you so much.